Hi, everybody. It's 6 p.m. in Paris, 5 p.m. in London, 7 p.m. In Beirut. And it is my great pleasure to welcome you all to this ICH monthly webinar. This is the September 2024 webinar. And the title is Transplant Indications in Lymphoma. As you probably know, in the last 3 to 4 years, we heard a lot about cellular therapies, especially CAR T cells in lymphoma. We've seen the advent of bispecific antibodies, antibody drug conjugates, and then obviously many colleagues are still hesitating or becoming more and more confused about the role of auto, but also allotransplant in different lymphoma entities. So today we are very pleased, honored, and privileged to have Professor Ali Bazarbachi from the American University of Beirut to address this topic. And Ali is the current chairman of the EBMT Working Party. So you would guess he's the right person to address this important topic. As usual, this is a live webinar, so please do not hesitate to send your questions, your comments, and at the end of the talk, when around 35 to 40 minutes, we will have a Q&A session. But for the time being, I'd like to invite Professor Bazarbachi to deliver his lecture. Ali, the floor is yours.
Thank you very much, Professor Mohty, for the kind introduction. Good evening, everybody, and I'm delighted to be with you today to talk about transplant indications in lymphoma, which is a vast topic. And actually, we have within the EBMT Lymphoma Working Party a dedicated educational course over 3 days to address this topic. So I will try to summarize in 35 to 40 minutes the transplant indications in lymphoma in 2024. These are my disclosures. So as you know, lymphoma, whether Hodgkin lymphoma or non-Hodgkin lymphoma, represents maybe something like 7% of indications of allogeneic transplant, but more than 1/3 of the indications of autologous transplants according to the EBMT survey. So there is still a very active transplant activity going on in the EBMT centers for Hodgkin or non-Hodgkin lymphoma. So starting with Hodgkin lymphoma, you can see on your left-hand side the EBMT recommendations for transplant indication in Hodgkin lymphoma in 2019, and on your right-hand side in 2022. These are the latest recommendation, and still autotransplant is recommended in first sensitive relapse as standard of care, and allotransplant is recommended as standard of care for patients mostly who relapse after autotransplant. Nevertheless, you can see on this slide from the EBMT registry that the numbers are going down for auto and allotransplant for Hodgkin lymphoma. So why the decline in transplant activity? Basically, it is because we have more effective drugs in the first-line treatment of Hodgkin with BV-AVD and more recently Nivo-AVD. And we have more effective drugs in the relapse setting. So this will make less candidates for autotransplant after first relapse and less candidate for allotransplant for patient relapsing after auto, because we have more effective drugs, and the denominator is decreasing. So as you know, and this is not new, Hodgkin lymphoma is a unique disease in that relapses can be salvaged, heading to cure in more than 50% of patients. So we can cure more than half of patients with Hodgkin lymphoma in relapse. Standard of care was and is still salvage, followed by autotransplant, but patients should respond to salvage therapy to obtain the best response before transplant. A revolution in the treatment of Hodgkin lymphoma in the last decade was the introduction of monoclonal antibodies, antibody-drug conjugate, brentuximab vedotin, and checkpoint inhibitors such as nivolumab and pembrolizumab. And these new drugs can be used as part of the salvage before auto, as consolidation or maintenance post-auto to prevent relapse, as salvage post-auto for relapse post-auto, bridge to allo, and as well as salvage post-allo. And more and more, these antibodies are combined with chemotherapy. So you can see here, combining BV with salvage chemotherapy will almost double the metabolic complete remission PET negativity from 35% with the chemotherapy regimen, such as DHAP, ESHAP, and ICE, to more than 70% when combining BV with salvage chemotherapy, resulting in more than 70% PFS. And actually, this metabolic complete remission does matter before autotransplant. As you can see here, whether PFS on your left-hand side or overall survival on your right-hand side are significantly better for the red curve for patients who obtain complete metabolic response as compared to the other partial remission or stable disease. And in this blood advance publication, you can see that BV plus chemotherapy versus chemotherapy alone in relapse refractory Hodgkin results in significantly improved PFS, event-free survival, and overall survival. We can also use checkpoint inhibitors combined with chemotherapy as salvage before auto, bridge to auto, and you can see these outstanding results from Moskovitz, where we have a PFS above 90% with 100% response rate, 95% CR, 30 months PFS, 96%. These are simply outstanding results. And the same is true for nivolumab. This is response-adapted anti-PD-1 based salvage with nivo or in combination with ICE, with 2-year PFS of 94%. And we can even use chemo-free strategies as a bridge to auto. For example, this publication from Advani in Blood 2021, where you can see the green curve is for patients who received a combination of brentuximab vedotin and nivolumab without any chemotherapy as bridge to autotransplant. And we are at a 36 months PFS, 3-year PFS of 91%. So with these outstanding results, very little number of patients is left for relapse after auto and for allo. So for patients who receive autotransplant for first relapse of Hodgkin lymphoma, this standard of care for patients who are at high risk of relapse is to use consolidation with brentuximab vedotin to prevent relapse, and the ATHERA randomized trial with the extended follow-up as you can see on your right-hand side, after 5 years of follow-up, we still have a major PFS advantage for BV consolidation after auto as compared to placebo. You can even use pembrolizumab as consolidation post-auto with outstanding results, as well as combination of brentuximab and nivolumab maintenance with this ASH 2020 publication. We are at 92% PFS for patients who received this combination for high-risk patients to prevent relapse post-auto. Still, we have patients relapsing after auto transplant, and historically we used to say that the survival of Hodgkin lymphoma patient who relapse after auto is dismal. Well, this is no more the case. You can see in this study that we performed within the EBMT lymphoma working party that the 4-year PFS has significantly improved over time from 35% to 61% for patients who relapse between 2015 and 2017. And if we look to more recent period, probably the results are better. And most of the advances were for the high-risk patient, the early relapse after auto within 12 months, where you can see on your left-hand side that we had a major improvement in overall survival. In late relapse results, survival is better, was better, and is still better. So why this improvement in survival for relapse after auto? Again, the monoclonal antibodies play a major role in that setting. For example, when using brentuximab vedotin for relapse after auto, we have a very high rate of response. However, the PFS with the antibody alone is quite short, except for the category of patients who obtain complete remission with brentuximab vedotin single agent. This is around 1/3 of the patient. The same is true for checkpoint inhibitor. You can see that nivolumab monotherapy for relapse after auto results in a short PFS, except for the CR patient. And the same is true for pembrolizumab from the KEYNOTE-87 study, short PFS, except for patient who achieve CR. So the monoclonal for patients who relapse after auto transplant are good, but not sufficient to cure these young patients. Don't forget that in the setting of Hodgkin, we are talking about patients between 30 and 40 for most of them. On the other hand, allotransplant, we have seen that the number of allotransplants are decreasing as an absolute number, but the use of allotransplant for relapse after auto has been progressively going up in the EBMT registry in this study, again, that we realized within the lymphoma working party. You can see on your right-hand side. So for those who relapse, there are less patients who relapse, but for those who relapse, we currently more than half are receiving allogeneic transplant with a plateau of survival around 55%. And actually, the results of allotransplant in Hodgkin have improved over time. And in this study by Anna Sureda, you can see that more than 60% of the patients are alive for patients who were transplanted between 2010 and 2014. And very soon we will be realizing a new study for the last decade, and probably the results will be even better. So what about using the monoclonal antibodies, brentuximab vedotin or checkpoint inhibitor, as bridge to allo if they induce a high rate of response, but the PFS is short? The idea patients with allotransplant. So we realized this study on 435 patients in relapse after auto. Half of them received BV bridge to allo, and the other were allografted without BV. And you can see that brentuximab vedotin allowed more heavily treated patients with 4 prior lines of therapy to have exactly the same outcome than less heavily pretreated patients. We can do allotransplant also after checkpoint inhibitors. So in the early days, we were faced with significant risk of graft versus host disease when allografting patients after checkpoint inhibitor. However, the results were quite good in terms of progression-free survival and overall survival. And now we have learned that allotransplant after checkpoint inhibitor, the best results are obtained when we use post-transplant cyclophosphamide for GVHD prophylaxis, regardless of the type of donor. And you can see here in this multivariate analysis that whether haplotransplant or match unrelated donor, when you use post-transplant cyclophosphamide, you have better results. So PTCY is probably the standard of care for allotransplant in Hodgkin after checkpoint inhibitors. And in this joint EBMT-CIBMTR study, allotransplant after checkpoint inhibitor resulted in significantly better progression-free survival without affecting overall survival. And this improvement in PFS was mostly due to a significant decrease in the risk of relapse, whereas non-relapse mortality was not affected. So the recommendations of allotransplant after checkpoint inhibitor is to hold the PD-1 therapy for at least 6 weeks before allotransplant, and to use a post-transplant cyclophosphamide-based GVHD prophylaxis. So in conclusion for Hodgkin is that autotransplant is still the standard of care for relapse refractory Hodgkin lymphoma, and that allotransplant is a potentially curative strategy for patients who fail autotransplant. Allotransplant might be deferred only in patients who achieve CR, and BV and checkpoint inhibitors can be safely used before or after allo with a time effect and PTCY use for checkpoint inhibitors. So now moving to diffuse large B-cell lymphoma, again, the numbers are decreasing in the registry while we still have significant numbers. 1,700 or 800 autograft were performed for diffuse large B-cell lymphoma in 2022. But overall, we have 20% decrease in autotransplant and 37% decrease in allotransplant. And at the same time, you have an exponential increase in CAR T-cell activity in the EBMT registry. So as you know, relapse refractory aggressive B-cell lymphoma is one of the oldest indication for autotransplant based on the PARMA study that was published in the New England Journal of Medicine almost 3 decades ago. And even in the rituximab era, Christian Gisselbrecht demonstrated that in the CORAL trial that autotransplant is still a curative modality for relapse refractory diffuse large B-cell lymphoma with no difference between RDHAP and RICE as salvage before autotransplant. However, if we analyze well the results in the rituximab era, you can see that the results are not that good for early relapse, where relapse occurs less than 1 year after first-line R-CHOP or R-CHOP-like first-line therapy. We can only cure 20% of the patients on your left-hand side when they are in early relapse. Conversely, for late relapse patients who relapse more than 1 year after first-line therapy, half of them can be still cured with salvage and autotransplant. And as Professor Mohty indicated, CAR T cells are gaining ground now for treatment of diffuse large B-cell lymphoma and relapse. Even in first relapse, 2 randomized trials. This is for the SUMA-7 study for axi-cel. You can see that we have significantly better event-free survival with CAR T cells compared to standard of care chemoimmunotherapy, salvage, and autotransplant. And the same is true for liso-cel and the transform randomized studies. And this has resulted in autotransplant moving for early relapse because these studies were realized, these 2 randomized studies were in early relapse in less than 1 year or primary refractory patients. So in early relapse, autotransplant is currently a clinical option, whereas it is still a standard of care in late relapse. Conversely, CAR T cells are standard of care for untested relapse or early relapse and a clinical option for late relapse. However, we have worldwide accessibility problems with CAR T cell therapy. You can see on this map the gray area in which CAR T cells are almost not realized because they are not available or very little. And even when we look to CAR T cell by recipient race, 80% of CAR T cell recipients are white and much less in Black and Asian populations. We have even in Europe and North America logistical issues with CAR T cells, such as insurance approval, manufacturing slot availability, and logistics of staying close to the center. And if we look well to the design of the studies, I'm not sure that the studies that were meant to compare CAR T cells with autotransplant in second-line treatment were performed ideally. Ideally, if you want to compare the 2 treatment modality, you start with inclusion, salvage, and then you randomize CAR T with versus autotransplant, which is the true comparison between the 2 modalities. And this was not the design of the studies. And when we look in 2023 to the American Society for Transplantation and Cellular Therapy recommendation, you can see that in diffuse large B-cell lymphoma with early relapse who achieve a complete remission or partial remission with salvage therapy, autotransplant is recommended as grade B with 88 and 96% agreement between the panelists. Still, CAR T cell in this indication is recommended with grade A. And conversely, for late relapses, autotransplant is recommended as grade A. And why this challenge of the indications? This came actually after this CIBMTR retrospective analysis that was published in Blood in 2022 for patients with diffuse large B-cell lymphoma and relapse who receive 2 or less lines of therapy and who achieve partial remission after salvage chemoimmunotherapy. The results were identical between autotransplant and CAR T cells. And if the patients achieve complete remission with chemoimmunotherapy, a very recent publication by Hamadani in Blood Cancer Journal a few months ago showed that the 2-year PFS is significantly better with autotransplant versus CAR T, and the progression or relapse rate is lower with autotransplant versus CAR T, and even overall survival is better with autotransplant versus CAR T. So the proposed treatment algorithm in diffuse large B-cell lymphoma is when patients are in relapse after first-line chemoimmunotherapy, if it is an early relapse, or if we are in a primary refractory setting, the standard of care is CAR T-cell therapy. However, if for whatever reason patients receive salvage chemoimmunotherapy and achieve PR or CR, autotransplant is yielding very good results. Conversely, for late relapses after 1 year, second-line chemoimmunotherapy, salvage, and autotransplant is standard of care. So what about allotransplant in lymphoma? Here you have a more dramatic decrease in the number of allotransplant in the registry, in the ABMT registry. And you're aware of the 3 approved CD19 CAR T constructs for aggressive lymphoma after more than 2 lines of prior therapy. The ZUMA-1, the study, the Juliet, and the Transplant study are all showing that CAR T cells is a curative modality for patient, including for patients who relapse after autotransplant. We also, as mentioned by Professor Mohty, also have, bispecific antibodies, mostly glofitamab and epcoritamab. And these results in very good PFS and overall survival, particularly for patients who achieve complete remission after bispecific antibodies. The previous slide was for glofitamab. This is for epcoritamab. And these treatment modalities, CAR T and bispecific, have predominantly replaced allotransplant. However, when we compare in the ABMT registry, allo versus CAR T in third-line plus setting for relapse refractory diffuse large B-cell lymphoma, you can see that PFS is better with allotransplant. Relapse incidence is lower with allotransplant, but non-relapse mortality is higher with allotransplant. And at the end of the day, overall survival is identical. We have a more recent ABMT study by Bertram Glass, again confirming these results, with non-relapse mortality being higher with allo versus CAR T, relapse incidence lower with allo versus CAR T, and PFS and overall survival are similar. We can still have a place for allotransplant following CAR T relapse. And in this Hematologica publication in 2022, you can see that allotransplant can offer a PFS of 45% with a plateau, with a 1-year overall survival of 59% for patients who relapse after CAR T cells. And okay, again, this is a more recent publication, again, confirming very good results for allotransplant at this indication. Now, moving more briefly to mantle cell lymphoma. Over time, autotransplant activity has been more or less maintained in the EBMT registry. Still, people are considering autotransplant as standard of care in first-line treatment of mantle cell lymphoma. But we have a dramatic decrease of more than 72% in allotransplant activity. Well, as you know, autotransplant has been established as standard after R-CHOP, RDHAP combination based on this randomized trial by Olivier Hermine and later on updated by Martin Drelling. And then the Lima study with Le Guil have shown that rituximab maintenance after autotransplant for 3 years significantly prolongs overall survival as compared to placebo. And more recently, the Lima 101 trial has established obinutuzumab as a potentially better monoclonal than rituximab. You can see, for example, on your left-hand side, the PFS above 90% with obinutuzumab, DHAP, autotransplant, and obinutuzumab maintenance with MRD guided strategy. So I would like you to focus on these results when we will talk in 1 minute about the triangle randomized trial, which compared 3 arms: R-CHOP, RDHAP, autotransplant observation, R-CHOP with ibrutinib, RDHAP, autotransplant, and 2 years of ibrutinib maintenance, R-CHOP, ibrutinib and DHAP, and 2-year ibrutinib maintenance without transplant. Half of the patients in this trial did not receive rituximab maintenance. Well, this triangle study showed that ibrutinib arms are better than no ibrutinib in terms of failure-free survival, so superiority of auto plus ibrutinib versus auto alone, and superiority of our non-inferiority of ibrutinib without transplant versus auto transplant, and probably superiority of ibrutinib. However, the blue curves are significantly lower than what we have seen in modern era using basically obinutuzumab, autotransplant, and post-transplant obinutuzumab maintenance for all patients. And these are the results in terms between comparing the 3 arms together. Overall survival is immature in this triangle study. So now moving to allotransplant in mantle cell lymphoma, which is a potentially curative consolidation strategy, but has relevant non-relapse mortality. Long-term overall survival in early days was 25 to 40% only. These are advanced disease settings. Non-relapse mortality was 20 to 40%. And actually, Brexucell CAR-T demonstrated superiority in terms of 1 year overall survival compared to allotransplant in this Lieber's publication. And long-term PFS was similar between the ZUMA-2 and allotransplant in terms of progression-free survival. Non-relapse mortality was higher with allotransplant. Relapse incidence was lower with allotransplant. And still, if we look to the NCCN guidelines, allotransplant is still considered as one option for advanced disease mantle cell lymphoma. So in conclusion, high-dose cytarabine-based induction, autotransplant, and rituximab maintenance is still the standard of care for young patients with mantle cell lymphoma. Promising results of Lima 101 phase 2 trial toward a new standard of care with obinutuzumab. BTK inhibitors have changed the landscape in relapse refractory mantle cell, and preliminary results of chemo-free BTKi-based therapy in newly diagnosed elderly mantle cell are excellent. The trial challenged the role of autotransplant in first-line treatment of mantle cell, but with optional rituximab maintenance, relatively short follow-up, potential long-term cardiac toxicity, and lack of approval in most countries. And the role of new BTK inhibitors remain to be defined. Very quickly about follicular lymphoma, here we have a drastic decrease in transplant activity, both auto and allotransplant. While allo was curative and can cure follicular lymphoma, this was published by Anna Sureda in 2018, but now we have bispecific antibodies, mosunetuzumab, offering very good PFS and overall survival with long-term survival in follicular lymphoma. And the ZUMA-5 for CAR-T is also offering excellent results. So finally, about allotransplant for B-cell lymphoma in 2024, yes, but it depends on the histology and specific subgroup of patient. For DLBCL, probably for relapses after CAR-T in a very selected subgroup of patients. For follicular lymphoma, no clear candidate in the setting of availability of bispecific antibodies and CAR-T cell. For mantle cell lymphoma, CAR-T cell is probably the preferred treatment option, but selected patient in the relapse refractory setting, if PR or CR is achieved, can go to allotransplant. And I would like to finish with peripheral T-cell lymphoma. As you know, long-term outcomes in peripheral T-cell lymphoma are bad for all histologies except the anaplastic ALK-positive patients. And in the EBMT recommendation, you can see that allotransplant is standard of care for chemosensitive relapse, and autotransplant is a clinical option in CR1. When we look to the registry, the transplant activity has been maintained for peripheral T-cell lymphoma, both auto and allotransplant, probably because we don't have CAR-T and bispecifics in T-cell lymphoma. The autotransplant use as consolidation after first-line treatment, CHOP or CHOEP, is based off this Nordic study, which was not randomized, but compared to historical control, offering relatively good results as compared to what you have seen with chemotherapy alone. And these results were confirmed by the complete study by Park published in Cancer in 2019, where you have in CR1 patients outstanding results with autotransplant for CR1 patients. Now we have brentuximab vedotin that is being used as part of the first-line treatment of peripheral T-cell lymphoma and the BVCHP. And even in this Echelon 2 study, patients who received autotransplant after achieving remission with BVCHP, the red curve did better than patients who did not receive consolidative stem cell transplant. And to have a clear answer about the place of autotransplant for DLBCL, we have to wait for the results of the French randomized study comparing autotransplant versus no transplant in CR1. For relapse refractory peripheral T-cell lymphoma, survival was dismal before. We know that we have a strong graft versus lymphoma effect with allotransplant, with relapse rate significantly better than autotransplant. And when we look to the results of allotransplant and relapse refractory peripheral T-cell, well, basically we have 35 to 50% of patients that can achieve long-term PFS. And in the French SFGM study, we have a 5-year EFS and overall survival of 53 and 57%. And the best results were for angioimmunoblastic T-cell lymphoma, followed by PTCL, NOS, and anaplastic. Haplotransplant offers also very good results in different settings of lymphoma except diffuse large B-cell lymphoma. And you can see that for peripheral T-cell lymphoma, we are at around 60% overall survival at 4 years. And when we compare auto or allo for relapse refractory PTCL, NOS, or angioimmunoblastic, results are significantly better for allotransplant. So I believe that autotransplant has very little indication for relapse PTCL. So in conclusion, hematopoietic cell transplantation is still a curative treatment strategy in patients with T-cell lymphoma. Autotransplant is considered a clinical option in CR1, except the ALK-positive patients who are cured without transplant. The benefit of autotransplant is being seen even in the advent of new drugs, and allotransplant is dedicated to patients with relapse refractory disease. And this is my last slide. You're all invited to the Lymphoma Working Party educational course that will take place in Rotterdam, in the Netherlands, between October 30 and November 1, 2024. Thank you for your attention.
Thank you very much, Ali, for really a fabulous and comprehensive talk. I think this was a tour de force, as we say, because in 40 minutes, you managed to walk us through all lymphoma subtypes and whether we should auto or allo transplant them. And we have already plenty of questions. One question we have from Dr. Odroj is about whether there is a way to prevent the subsequent toxicities of checkpoint inhibitors when patients are receiving an allo transplant after checkpoint inhibitors.
Thank you, Professor Mohty. Yes, this is a very good question. And I think that we have learned how to use checkpoint inhibitors as bridge to allotransplant. So in the early days, we were faced with a high rate of graft versus host disease. And even it was mentioned that we had a high risk of veno-occlusive disease when doing allotransplant after checkpoint inhibitors. But now, if we follow the two major recommendations to hold the checkpoint inhibitors for 6 weeks at least, so between the last dose of checkpoint inhibitor and the allo, and to use post-transplant cyclophosphamide as GVHD prophylaxis when doing an allotransplant after checkpoint inhibitors, I think that we have seen that non-relapse mortality has gone down significantly.
Excellent. Thank you very much. We have another question in terms of auto, and if there is an indication for an auto, and maybe I will broaden the question of Dr. Jassat about the optimal high-dose chemo or conditioning, because we know that the classical beam is a standard of care. However, we may have a shortage of BCNU or other drugs. So any alternative, bendamustine, thiotepa, bendaime, team, or any other combination? Any thoughts on this?
Thank you, Professor Mohty. This is again a very important question. So actually, we have a lot of publications about conditioning in autotransplant for lymphoma. When we look to the EBMT registry, 80 to 90% of autografted patients are receiving beam, but in the face of a shortage of BCNU, the three or shortage of melphalan. We have the three most used regimen where for shortage of melphalan, BEAC, replacing melphalan with cyclophosphamide. And at one time, we had an alert about possible cardiotoxicity when using high-dose cyclophosphamide as part of the conditioning. This was not confirmed. So I would say I would still use melphalan rather than cyclophosphamide. For BCNU, the results are less clear. We have two challengers to BCNU, bendamustine and thiotepa. Bendamustine has been reported to increase renal toxicity. So I would use it if I don't have BCNU or thiotepa. Conversely, for thiotepa, multiple studies, including studies from the department of Professor Mohty, testing team by Rémi Duléry, have shown outstanding results with team. So I would say that team and beam are standard for conditioning. We prefer team thiotepa when we have CNS disease because of better CNS penetrance of thiotepa compared to BCNU. Outside the setting of CNS disease, I think that both are very good regimens.
Excellent. Thank you very much. Let's move now. We have a question about mantle cell lymphoma. And what is the current status of auto in mantle cell? Are there still patient who would be candidate to auto transplant with mantle cell lymphoma?
Basically, in first-line treatment of mantle cell lymphoma, I showed you the numbers in the EBMT registry showing that we have only 0.7% decrease in the use of auto transplant as first consolidation. So the triangle study has challenged the role of auto transplant in mantle cell lymphoma, but the triangle study has 4 types of biases. The first one is that more than half of the patient in the triangle study did not receive any maintenance post-auto transplant, whereas we know very well that at least rituximab prolonged PFS and overall survival. And in the ibrutinib arm, patients are receiving ibrutinib maintenance. In the placebo arm of ibrutinib, half of the patients are not receiving any maintenance. So if ibrutinib is not curative, but just delaying relapse, the clock will start for ibrutinib at year +2, at 2-year or 3-year post-auto transplant, whereas the clock will start for the placebo arm at day +1 post auto transplant. So I think that this is a significant bias. And if you look to the PFS curve of the standard arm of the triangle study, the results are significantly lower to what we have seen, for example, in the Lima trial, where we have more than 90% PFS. Two, currently with a strategy of high-dose cytarabine with anti-CD20 induction, auto-transplant, and anti-CD20 maintenance, we have more than half of the patient who did not relapse after 10 years. So I know that we always debate about the significance of the word cure in oncology, but I think that a patient who did not relapse after 10 years is a functionally cured patient. So we have a well-established curative strategy with a very long follow-up, and I think it's probably not very wise to abandon a curative strategy for another one with a much shorter follow-up. And the third aspect is a lesson that we have learned from multiple myeloma. Many studies who showed the advantage of auto-transplant or for any treatment, you see the advantage after 4 to 5 years where the PFS curve start to diverge. So currently, when we compare in the triangle study, the auto-transplant with ibrutinib versus ibrutinib without auto-transplant, which is the comparison that challenge auto-transplant, there is no difference, but the follow-up is very short. Maybe in 3 or 4 or 5 years, we will start to see the ibrutinib arm patients relapsing because ibrutinib was stopped, and the auto-transplant, we know that we cure more than half of the patients.
Excellent. Thank you very much. We'll take one last question, and this is about allotransplant in Hodgkin lymphoma. And the question, if you have patient who relapsed after brentuximab, they were salvaged with checkpoint inhibitors, they underwent a haplotransplant, is there any suggestion for maintenance therapy after transplant?
Currently, there is no standard maintenance after allotransplant. We rely on the graft versus lymphoma effect of allotransplant. It may be dangerous to use checkpoint inhibitors after allotransplant because you can induce corticoresistant graft versus host disease. We do it when we are forced to do it for patients who relapse after allotransplant. But as a preventive strategy, and we have observed it the hard way of patients developing grade 4 liver GVHD when using checkpoint inhibitors for relapse after allotransplant. So I don't think that we can use outside a clinical trial checkpoint inhibitor for consolidation after allo.
Okay, so I'll take one last question because some colleagues are insisting. What would be the optimal treatment for transformed lymphoma, Richter syndrome?
For Richter syndrome, basically, Richter is mostly CLL. Currently, what we are doing for Richter and CLL is R-CHOP with venetoclax, and patients are achieving a very high rate of remission, complete remission, and then we are continuing venetoclax for 2 years, and then either alone or combined with ibrutinib, depending on whether patients progress under ibrutinib or not. But we're not using ibrutinib with in the R-CHOP period. We're not doing transplant in Richter. I know that there are good results with transplant in Richter, but we have seen very good results in multiple patients with venetoclax and chemoimmunotherapy. And most of the patients are quite old in CLL. And you know that non-relapse mortality with allotransplant in CLL has been frequently reported to be relatively high.
Well, excellent. Thank you so much, Professor Bazarbachi. It was a true delight to have you with us. Thank you all for your participation, for your attendance. I hope you have enjoyed this beautiful webinar for the month of September. Please don't forget that in around less than 10 days, we will have the ICH annual meeting in Paris. And this is a meeting where you can be in person or you can follow the whole meeting on the virtual platform. So wherever you are, please stay safe and keep well. This is the ICH around the globe and across the hematology field. Thank you.